The pandemic laid bare a truth that we already knew, which is that there are enormous disparities in the healthcare system, and that those disparities are worst among Black and Indigenous people of color.
I'm J.B. Wogan from Mathematica, and welcome back to On the Evidence, a show that examines what we know about today's most urgent challenges and how we can make progress in addressing them. Our guest for this episode is Chris Trenholm, the Managing Director of Health at Mathematica. For those who don't know, the Health Unit is the biggest of our 3 units at Mathematica, with nearly 600 staff, including healthcare and policy experts, researchers, technologists, data scientists, clinicians, survey experts, and program design and management experts who work for government, philanthropic, and private sector clients. Just on the research side, we've studied or are currently studying primary care payment models, perinatal mood and anxiety disorders, telehealth policy, electronic health records, soda taxes, wastewater epidemiology, treatments for substance use disorders, and a lot more. And we have a substantial body of work that isn't research or program evaluation per se, but draws from the same skills to provide advisory services related to the successful implementation of the Affordable Care Act and broader progress in creating a more value-based and equitable system of healthcare. Given that we are living through a historic pandemic, I thought it would be enlightening to hear Chris's reflections on COVID-19's impacts on healthcare in general, as well as Mathematica's work related to healthcare. Chris is an economist by training, and his 23-year tenure at Mathematica includes the Great Recession, so we talk a little bit about how this moment compares to the last major economic crisis. We recorded this interview in early June, as communities across the country were organizing protests against racism and police brutality, which is important to keep in mind as Chris draws a connection to the topics of racism and racial disparities in health outcomes. I hope you find our conversation useful. Okay, so big picture, how has the pandemic changed Mathematica's health-related work? And take that in whichever direction you like.
The pandemic has really impacted our unit's work and the work of Mathematica really across the board. And I guess I'll start with the existing work that we do with our clients. Quite a bit of that work is in building the evidence base, in conducting data collection and evaluation and research in support of improving health and healthcare. And in that case, that's done in collaboration with the healthcare community. And in that work, we've had to be very careful and redesign, and in some cases simply reduce our work in order to ensure that the work of research, evaluation, data collection does not interfere with the critical work of responding to the pandemic. So we have really done our best working with our clients to try to respond to that and see that we continue to make progress on building evidence, but do so in a way that is not interfering in any way with response to the pandemic. With respect to work that we do that's more advisory, where we're partnering with actors in the healthcare field to strengthen programs and strengthen policies and decision-making, there it's been a different response. It's been a response of really redirecting and reinvesting our work and expertise in response to COVID. And there are lots and lots of examples. Many of them are in building data and monitoring and access to information that can help inform responses to the pandemic, policy responses. But maybe I could just illustrate one example of that that's been gratifying. We do technical assistance work to support the implementation of a Medicare payment model that is designed to encourage hospitals and provider systems to screen for risks to social determinants of health, and for patients who are identified at risk to see that they receive successful referral services. So when I say social determinants, I mean issues of homelessness, food insecurity, domestic violence being good examples. And those screening services were provided in the hospital in a visit. And when the pandemic hit, that was not going to be possible, both because those hospital staff needed to move to the front lines of the pandemic, but also because so much healthcare was moving virtually, moving to telehealth. And that presents real challenges for screening. And the most obvious example is screening for domestic violence, where the tools that one would use to screen for that in person are not going to be successful in a virtual setting where someone subject to domestic violence may be in an environment that's unsafe for them. So we have worked with the Medicare program to try to see that we can sustain that payment model and continue to do that screening, but to do it successfully and safely in a virtual setting. So that's just one example of many where we've had the opportunity to partner and do work to continue to respond to the pandemic or to our work successfully.
All right, so I know there are a few things where in a relatively short time frame, like a few months, we've made direct investments to develop new tools and resources in response to the pandemic. Talk a little bit about the things that we've done outside of, say, existing partnerships and contracts.
A lot of that is in building data analytics and data evidence-driven solutions to strengthen the response to the pandemic, the policy and programmatic and decision response to the pandemic. And as examples of that, we've got substantial capability in contact tracing and are bringing consulting support to that. We've also implemented analytics solutions to allow municipalities to monitor outbreak and to have kind of advanced warning systems of outbreak through the use of wastewater to monitor the disease. We have successfully built forecasting tools that can be used to assist organizations in responding to the pandemic, and that's become particularly important in places like universities and schools, which are trying to figure out the way that they can open as safely as possible. And we've been providing support with tools that essentially predict the risks to COVID infection, kind of depending on which levers or which approaches are taken to opening schools, opening employment, steps like that. We've also developed individual risk tool. You actually can Google 19andMe, and I think after maybe a pop song comes up, you'll find a link to Mathematica website where you can actually provide some basic information about yourself and how you're behaving in this pandemic environment, and it will return to you risk score indicator. We've also built other tools and supports to organizations which, again, are trying to maintain themselves in the pandemic. Wonderful example is support that we're providing to a hospital system where we've stood up an analytic tool that allows them to see their workforce every day and understand who is able to make it to work that day, who is sick, who's infected, and manage those resources as well as possible across the front lines of the system, and also likewise try to manage their other resources. So all of that is really just trying to respond to the best of our ability with kind of our intersection of data capability and technology and other types of expertise. So it's been an exciting and important time for us as an organization.
In terms of agencies' changing needs and changes in the broader health policy agenda, how would you say this moment compares to the Great Recession?
I think with respect to healthcare, there was one central element of in the response to the Great Recession, which was the ARA, the American Recovery and Reinvestment Act. That was the $1 trillion that basically was put out to try to, again, stimulate the economy and make important investments in infrastructure. And in healthcare, the one thing that the investments went towards, in particular, was I think tens of billions of dollars to begin to redirect or incentivize the healthcare system into technology to build health information technology systems that would be needed in the future, and to begin to encourage and incentivize the adoption, widespread adoption and implementation of electronic health records. And I think when you take that investment and you couple it with the passage of the Affordable Care Act, which was further incentivizing a data-driven movement in the U.S. healthcare system away from one that rewarded volume of care to one that was rewarding and is trying to reward value of care. A decade of the 2010s, it was about big data for the first time in healthcare, and really the tools of data science beginning to emerge in healthcare and healthcare policy for the first time. I think when you jump to today, it's a different story because the entire pandemic is a health experience. And it's difficult in June to predict where this is going to go in, say, the 2020s. But there's a couple, I think, fairly obvious things to say. The first is there was already recognition of the potential of telehealth and virtual medicine in healthcare as a benefit, as an asset. And I think what we've seen is, for sure, an acceleration of that. It's hard to predict what and how that will look in the coming years post-pandemic, but I don't think there's any question there's a much more open appetite for telemedicine. You're going to see investments on the healthcare side in that as well. So that's one obvious statement. The second is maybe hasn't been said and observed. It's been observed, but hasn't been talked about enough yet. It's maybe too real time or maybe even too raw, which is the public health system in this country has really struggled in its response to the pandemic, and it's not for lack of the individuals in that system responding beyond heroically. Where the struggle has been is in the ability of what is a U.S. public health system that is locally based. It's founded in communities. It is a decentralized system, and appropriately so. I think there are many, many examples of the benefits of that. So it's a system that I think I and many others would continue to endorse. But when a pandemic strikes, there have to be mechanisms for that local to connect up to larger entities, to regions, to states, and ultimately up to the federal system, so that the response to the pandemic can be appropriately monitored and there can be timely responses in terms of guidelines and investment. I think despite all those investments in the 2010s, the technology and data infrastructure that exists in the public health system was not able to respond as successfully as it needs to. And I'm hopeful that in the 2020s, with that recognition, that we'll be able to make the right investments and really build a system of public health that is not only responsive at the local level, but is data-driven and evidence-based through the entire system, from its center point federally all the way down and back up.
So some of our listeners may already know that Mathematicas' mission is to improve public well-being, and that manifests in various ways depending on the partner and the project. I've seen it in terms of helping people who've lost a job get back to work, making kids have adequate access to nutritious meals, providing people at risk of heart attacks or strokes with more preventative care before complications occur, and I could go on and on. But I think advancing racial equity is implicit and a big part of that larger mission. What does the pandemic mean for Mathematicas' goals to improve public well-being while advancing racial equity in healthcare?
Yeah, the pandemic laid bare a truth that we already knew, which is that there are enormous disparities in the healthcare system, and that those disparities are worst among Black and Indigenous people of color, that they suffer disproportionately across all of those social determinants of health, across basically every indicator of chronic illness. And we're seeing it again in the pandemic with the fatality rates being much higher among Black and Indigenous people of color. And, I think just wrapping it up in the events of recent days, I think it's entirely possible, if not likely, that would be a data point and an experience that would be observed and written about, and there would be a desire for change. I'm hopeful that the experiences of the last days and the response of this country in believing in the necessity to combat racism can bring more than a recognition of what the pandemic has yet again exposed, which is the disparities in this country in the healthcare system, and that we can be much more intentional and demand that the healthcare system respond more successfully in seeing that those disparities aren't that they're eliminated, that we really set to that task, and that we recognize that they are rooted in racism.
So I have another question that is about how things are different now compared to the past. In terms of what we can do and how we can help our partners respond to a crisis, how would you say this moment compares to the Great Recession or even earlier periods of Mathematicas history?
That's a good question. I think there's two ways in which things are different now, and of some extent maybe touched on both. I think the first is the capability of data and data science, despite my critique of the public health system compared to the past, certainly 10 years ago. The data and data science capabilities in responding to the pandemic are far more substantial than they've been. Basically, every tool that I described to you that we've invested in and looked to support decision makers in response to the pandemic, whether it's that wastewater testing or the 19andMe tool or the predictive model, even elements of contact tracing in terms of the technology infrastructure required to do it successfully, all of those would have more than likely not been feasible 10 years ago. So I think there's an ability to respond to the pandemic. There's a medical story here, which is really a story that is outside the expertise of Mathematica, but I think in terms of the policy and programmatic response, the data availability and the ability for methods and solutions, analytic solutions to be put forward in response to the pandemic is just far better than what it was. I think the second is I mentioned in the example of Mathematica's work around social determinants of health, that has been a growing conversation over the course of the last several years, that if you're going to be serious about improving the U.S. healthcare system and closing disparities in healthcare and health outcomes, that you're going to have to address these social determinants of health. And I think that that's very important. So I think that's a benefit because I think we know where to focus in terms of making substantial change in terms of moving forward the health of Americans, particularly those who are disadvantaged or suffering. But again, if I come back to the situation we find ourselves in today, I don't want to kid ourselves that that's not only not easy, but that it's going to take a reckoning that recognizes that underneath those social determinants of health are institutions and systems that are in and of themselves racist. And I think for a place to explore that perspective, which is my own, it's my individual perspective, I'd encourage everybody to read the article by Alan Weil. Alan is the editor of Health Affairs and a brilliant health policy thinker and a beautiful writer. And he's written a piece called Social Determinants of Death, where he puts forth his perspective, which I share, about what needs to change in the healthcare system, that we have to acknowledge the underpinnings of racism and race, and we have to be virulently anti-racist in pushing institutions and healthcare as an example of American institution towards the light. And that's really the path by which we make real progress in social determinants of health. And Alan has a wonderful quote to close his piece. He says, "It's not enough for healthcare institutions to stand up against racism or with those who protest it. The test of the day is whether those institutions will use their power to fight racism." And I believe that this is more than a moment, and that there's an ability here in the 2020s, an awakening to respond to these issues in healthcare like we haven't, say, 10 years ago.
It seems like the pandemic offers a glimpse of how organizations can use methods in data science to quickly provide some useful information during a crisis. But I have to imagine that these types of tools are going to be even more in demand in calmer times. With regards to policy research and data science, where do you think we are headed? Or at least where do you hope we are headed?
I think if I had to do it over again, JP, I'd probably write my dissertation on this question, because I think it's a really important question and an enormously important space for healthcare and for policy in general going forward. First of all, the term data science gets used everywhere. In fact, it's used so often now I don't know that it means very much at all to anyone. If you go online and Google data science and look at images, what you'll see often is a picture that shows three circles. One is IT or technology, the other is methodology or kind of advanced statistics, and the third is what will often be called domain expertise. And so the concept of data science is that it resides at the intersection of that you intersect big data and technology and advanced statistics, and then you bring in sufficient domain expertise, you really can provide transformational learning. And ideally, you can actually allow machines to continue to learn and iterate, to continue to make progress. And I think the 2010s is a period of enormous advancement in that. I think you don't need to be much of an American consumer to know that. The reason why Netflix already knows your shows and Amazon already knows what you want to buy is because of that success at that Venn of the interaction of those three relationships. I think, though, that when you move from a closed system or a system where all the data can be available and relatively complete to a social science setting, to a policy setting, which is ultimately a human story and a human endeavor that is enormously complex. That idea of that third bubble that is called domain expertise becomes enormously more complex. And so I'll just illustrate this with one example, the Medicaid program. So think about the ability for data science to have supported baseball. So the book Moneyball and the idea of helping scouts be more successful in predicting and building successful baseball teams. Well, the domain expertise required there is largely residing in those scouts. They can tell you everything that one would need to know about the human experience of a baseball player and largely teach the machine, and that's where lots of success has clearly emerged. That's how Red Sox have won a World Series, and the Cubs have won a World Series, the Nationals have won a World Series. But when you move to something like Medicaid, it's infinitely more complex. Here you have an insurance program, a federally financed insurance program that is different in every state, District of Columbia, different in every U.S. territory. It also serves profoundly different populations in truly different ways. It is designed to serve low-income children, lower-income and working-class families, disabled populations, frail elderly, and individuals who have become so sick that they've essentially lost their wealth or income, and so that safety net is there for them. So consider the fact that I've just described kind of 5 entirely different populations that need to be served 5 entirely different ways, and I've just mentioned 50 to 60 different programs. Well, now you're talking about 250 to 300 different versions of the Medicaid program at the most superficial level. And then in each one of those implementations is a story that goes much deeper in terms of how the healthcare system engages, what the provider community looks like, how care is financed, what access looks like, who the population is. And so you now step back and think about data science and think about this concept of the IT and the methodology building the machine that can learn. And then you step down into the domain expertise. Well, the domain expertise required to teach the machine enough about the Medicaid program that it can improve the Medicaid program is incredibly significant and complex. And so the ability of data science to succeed in policy is going to require us to understand that it is far less about continued advances of the machine. Those advances are going to come. Google is going to make those advances. Those advances are moving. The question is, who and how do we teach the machine to be successful in improving public well-being in policy? And that is an incredibly complex question, and it requires at the table, at a minimum, people who are truly expert in data, people who are truly expert in subject matter or domain of a program and a population. And thirdly and critically, people who are expert in the risks of that machine. So people who understand the biases that may exist in that human teaching or in that human data, people who bring an ethical lens, people who bring a lens of Black and Indigenous people of color, voices that have been discriminated against need to be at that table along with those other types of expertise. That is so infinitely more complex, JB, than a scout to make a baseball team better. So that's what it's going to take. For data science to transform policy, it's going to take that level of investment in humanity, in human teaching of that machine. And, the 2010s were kind of a period of hubris where IBM got, I'll pick on IBM, although I want to acknowledge and respect them as pioneers in this. They beat Kasparov at chess, and then they won at Jeopardy, and then they believed, I think, in the 2010s that they could replace an oncologist diagnosing a cancer. And again, a much more complicated picture, and one that we just haven't been able to figure out. And I can't emphasize enough, JB, too, that we've already seen evident failures in the 2010s in terms of teaching that machine on the edges of policy. And the failures have been threatening. The most, I think, recognized example is in criminal justice, where for completely appropriate reasons, the criminal justice system buried in caseload, which was not good for anybody in that system, looked to move more efficiently through sentencing and to leverage data science and the tools of data science to inform sentencing so that the machine could help with the sentencing and move along the cases more quickly. That has been an abject failure, not just a failure in terms of the sentencing not being accurate, but the sentencing has reflected racial disparities and racism. And it speaks, I think, precisely the point that I'm trying to emphasize, which is in the case of sentencing, human expertise, which is about teaching the machine to be human, to bring humanity, was missing. So I have enormous optimism about the potential of the machine to transform healthcare, but it is going to take a transformational change in how humanity and social science and the tools of social science engage that machine, because the machine doesn't care. So we have to bend it to the will of humanity and see that it is servicing a mission of public well-being.
Chris, thanks for taking time to share some reflections and come on the show today.
Thank you, JB. It's been a true pleasure.
Thanks for listening to another episode of On the Evidence, the Mathematica podcast. In the show notes, I'll link to the piece Chris referenced by Alan Weil on the social determinants of death. Keep up with the latest episodes by subscribing on Apple Podcasts, Spotify, Stitcher, or wherever you find podcasts. To stay up to date on the show, as well as other interesting work from Mathematica, follow me and Mathematica on Twitter. I'm at JB Wogan. Mathematica is at Mathematica Now.